Hi everyone, I'm Dr. Ila Jain Khandelwal, and today I'm going to discuss the important hematology images from pathology which can be asked in your FMGE exams, right? Now, these images, students, are those which are extremely important, and I have divided this module into two, the hematology images. In this hematology images 1, we are going to discuss the images which are important from WBCs, right? In the next module, which I will be releasing after 5 days, there will be images from red blood cell disorders, right? So students, these images which I'll be discussing are very, very important. So my request to all of you is that if you want crisp and thorough revision of the important hematology images, please go through these videos, right? So let us start the important hematology images from WBCs for FMG or NEET exams, right? So let us move to the first image, students. Before I move on to the WBC disorders, I want to tell you some basic things, right? How to identify the various blood cells. That is the basic thing which you all need to know, right? So in this image, you can see that this cell which you see is the normal RBC, right? Here we have 5 types of WBC, students, which are there. This WBC, which you people can see, is binucleated with brick red granules, is actually a eosinophil, right? Here, there is a basophil. How will you identify a basophil? You identify a basophil by the dark purplish granules. Can you people appreciate the dark purplish granules here? Right, so that is a basophil. Then students, this is a normal neutrophil which will be having approximately 3 to 5 lobes with the bluish purplish granules. This is a normal lymphocyte, which is actually the smallest blood cell, which is a granulocyte. So there will be no granules in the cytoplasm, as I can see in this image, and it is a very small cell with a round nucleus, right? Monocyte, on the other hand, is also a granulocyte. There are no granules in the nucleus, right? In the cytoplasm, I'm sorry. And the important point to identify a monocyte is it is the largest blood cell with a horseshoe shaped or a kidney shaped nuclei. Can you all identify in this image the kidney shaped nucleus, right? So this is actually a monocyte, right? This again is a neutrophil. And this small patches which are there, these are the platelets. So I hope now you all know how to identify the various blood cells. So in the MCQ exam, you can get a question like, a patient has got an allergic disorder, which of the following blood cell increases? So the examiner wants to ask you, which is the kind of cell which increases in allergic disorder? The answer is eosinophil. You have to identify a eosinophil. Agreed? Got it? Now let us see how a normal bone marrow aspirate looks like. When you see an image like this, right, with a lot of cells, which are basically the RBC precursors, the WBC precursors, and the megakaryocytic precursor, it is a bone marrow aspirate, right? This is a normal bone marrow aspirate. Important thing to take home here is that the normal myeloid to erythroid ratio is 3:1 to 15:1. It has such a wide range, but if you have to mark one answer, the answer is 3:1. That is the best answer, right? In the MCQ exam, it will be given whether it is a peripheral smear or a bone marrow aspirate or a bone marrow biopsy, right? Now let me show you a bone marrow biopsy also, right? Whenever we take a biopsy, you will see bony trabeculae, right? So this pinkish thing which I see here, this pink thing, this is actually a bony trabeculae, right? This is the HNE stain, okay? And these globules which are you are seeing here, these are actually the fat, and this is the foci of cells which is there, right? So these are the foci of cells which are there. This is a bone marrow biopsy, right? Understood the basic things? Now let me move to the important white blood cell disorder, and the first image, students, which is very commonly asked in the FMG exam, students, for the past 5 years, whether it is your INI-CET or FMG or NEET exam, this is one of the examiner's favorite topic and favorite image, which I feel even if you are sleeping, you have to know this. That is Hodgkin's lymphoma, and the characteristic Reed-Sternberg cell, right? Can you people see the cell, students? It is a binucleate cell. Can you see two nuclei, everybody? These are the two nuclei which I'm talking about, and there are prominent nucleoli which are pinkish in color. So this actually looks like a owl's eye. That is why this is called as a owl's eye appearance, right? Prominent eosinophilic macronucleoli. Another very important point to take home is that what are the markers? The markers are these cells are CD15 positive and CD30 positive, except for nodular lymphocyte predominant Hodgkin's lymphoma, in which both these markers are absent, right? So very, very important image you have to know for FMG exams for sure, right? Let's move to a variant of this Reed-Sternberg cell, which is called as the lacunar Reed-Sternberg cell. What is it called? It is called as the lacunar Reed-Sternberg cell. What do you mean by a lacuna? A lacuna is an empty space, right? Here, can you see there is a cell and then there is an empty space around it? So that is why this is called as a lacunar Reed-Sternberg cell. Two important points to take home regarding this. In which type of Hodgkin's lymphoma do you see lacunar Reed-Sternberg cell? Answer is nodular sclerosis. And the other is these are also CD15 and CD30 positive, right? Very important, correct? Let's move to the third type of Reed-Sternberg cell, that is called as a popcorn or the lymphohistiocytic Reed-Sternberg cell. Now, two important points to take home here are it is seen in nodular lymphocyte predominant Hodgkin's lymphoma. And for everybody, this nodular lymphocyte predominant Hodgkin's lymphoma is a non-classical Hodgkin's lymphoma. That is why, students, it is CD15 and CD30 negative. What are the markers for that? CD20 positive, CD45 positive, and epithelial membrane antigen positive. That is a very, very important point which you need to know. Correct? Now you will not make a mistake for any of the types of Reed-Sternberg cells, right? Next, let us proceed to the next image, students. This is a gist of whatever I have told you till now. This is a characteristic Reed-Sternberg cell, which is binucleate owl's eye appearance. This is with a single nuclei. That is why it is called as a mononuclear variant. This is the lacunar variant, in which I can see a clear space around it. And this is the popcorn cell because it looks like a popcorn. I always keep on saying that we pathologists are very fond of food items, right? So because this nuclei or the cell looks like a popcorn kernel, that is why it is called as a popcorn cell, correct? Now, before I progress to the next image, this is the table which I have made, and this table is extremely important, and I can guarantee one or two questions from this table in any of your MCQ exams, especially the FMG and the INICT, right? So let us quickly revise the important questions regarding this. If the examiner asks you what is the most common type of Hodgkin's lymphoma, the answer is going to be nodular sclerosis, right? If the examiner asks you what is the most common type of Hodgkin's lymphoma in India, then only the answer is going to be mixed cellularity. Remember, all types of Hodgkin's lymphoma are more common in males, right? Except for nodular sclerosis, which occurs equally in males and females, correct? Then, I've already told you, lacunar variant you see in nodular sclerosis, and lymphohistiocytic variant or popcorn cell you see in NLPHL. Now, once this question was also asked that which is the type of Hodgkin's lymphoma which is never associated with Epstein-Barr virus, right? Two other things regarding Hodgkin's lymphoma, students. It is a B-cell lymphoma, usually caused by EBV, Epstein-Barr virus. Which is the type of Hodgkin's lymphoma not associated with EBV? The answer is going to be NLPHL. That is the best answer. If that's not there in the option, then the second best answer is nodular sclerosis, right? All types of Reed-Sternberg cells are CD15 and CD30 positive. Also positive are PAX5. Another marker which is positive is PAX5, except for the non-classical one, that is NLPHL, which is CD20, BCL6, EMA, and also CD45 positive, right? If they ask you which is maximally associated with HIV, the answer is going to be lymphocyte depleted. If they ask you the worst prognosis, the answer is going to be lymphocyte depleted. This has got the worst prognosis. And if they ask you the best prognosis, the first best answer is going to be NLPHL and the second best answer is going to be nodular sclerosis. Understood? Hodgkin's lymphoma in detail, a very important high yield topic for all MCQ exams, right? This is this much you definitely need to know, correct? Let's move to the next image, students. Again, one of the examiner's favorite image, right? Every year, whether it is FMGE, NICT or NEET, they ask a question on this image and this topic. The topic is called as Burkitts lymphoma, and this image, students, when we take a lymph node biopsy from a patient suspected of having Burkitts lymphoma, it shows a characteristic starry sky appearance. Why does this appearance happen? This happens because you have a background of lymphocytes which are bluish in color. So they look like the sky. The sky is blue, right? In contrast, in between them are these tingible body macrophages. Can you people see these? So these tingible body macrophages are also called as histiocytes, right? They appear as if in the blue sky of lymphocytes, these stars are twinkling, correct? So that is why this appearance is called a starry sky appearance, which is present in a patient of Burkitt lymphoma. What are the other clues for Burkitt lymphoma? Let us quickly revise. Usually seen in children, African children, and usually Epstein-Barr virus associated. The common sites which will be a hint for you in the exams are jaw or a mandibular swelling or some lesion in the GIT like a ileocecum or the peritoneum. Correct, two important clues. Then the other thing which they commonly asked is the translocation. Please remember this translocation, extremely important. T8:14 or CMYC is the most common translocation which is present. This tumor is a very rapidly progressive tumor with a very high proliferative index, but the only good part about this tumor, it is highly chemosensitive, correct? The last is the marker, it is BCL6 positive. Done? Next image, students, is hairy cell leukemia. Again, a very important topic. What you need to know about hairy cell leukemia. First of all, students, you should know that it is a B cell disorder. First basic which I need to know is it's a B cell disorder characterized by the presence of these cells which are called as hairy cell. Another thing which I can see in this image is the rouleau formation, that is RBCs are aggregating one after another, correct? Clinically, the patient usually presents with massive splenomegaly. So that is one clue. For massive splenomegaly, in the MCQ exams, you have to think about CML, malaria, Kala-Azar, hairy cell leukemia, myelofibrosis, the 5 important diseases which you have to remember, right? When you do the bone marrow aspirate in a hairy cell leukemia patient, usually shows the presence of dry tap. Another very important point, students, usually shows the presence of dry tap. Why? Because these patients usually have myelofibrosis, right? In myelofibrosis, you usually have dry tap. That is why what we have to do is bone marrow biopsy. And what I see when I do the bone marrow biopsy, I see a fried egg or honeycomb appearance. Here I will tell you a flashcard which you need to remember in pathology. The two important fried eggs in pathology are bone marrow biopsy of hairy cell leukemia and the CNS biopsy of oligodendroglioma, right? Brain tumor, oligodendroglioma, and the bone marrow biopsy of hairy cell leukemia. What is a special stain which I use for a hairy cell leukemia? The answer is tartrate resistant acid phosphatase. And what are the markers which are there? Annexin A1, CD25, CD11C or 103. All these are important MCQs, correct? Let me show you important image, students. Fried egg. Why do you say it is fried egg? Because you see a nuclei and a clearing space. It looks like as if you have fried the eggs, something like this. That is why it is called fried egg appearance. These two are the conditions in which it is seen. Easiest story till now, right? So hairy cell leukemia, Burkitt lymphoma, Hodgkins lymphoma. Three important topics over. Let us move to the next important topic, students, that is leukemias, right? Leukemias are also very, very important. Let us move to the first important thing about leukemia, students, that is lymphoblasts, right? You all know what are blasts. They are immature cells, right? Now, blasts are immature precursor cells. If it is an immature precursor cell for lymphocyte, it is called as a lymphoblast. And if it is an immature precursor cell for a neutrophil or a cell of the myeloid series, it is called as a myeloblast. And why do you need to know and identify blasts? Because when the blasts in the peripheral smear or bone marrow are more than 20%, usually signifies that patient has got acute leukemia, right? According to WHO, right? How will you identify lymphoblasts? They are the cells with scant cytoplasm. Can you see scanty cytoplasm here, right? No granules. Does lymphocyte has granules? No. That is why the precursor will also not have granules. So it has no granules. Coarse or bluish chromatin, right? Can you see? It has a very purplish or bluish chromatin and inconspicuous nucleoli. I can't see many nucleoli. These are the four very important characteristics, students, to identify a lymphoblast, right? But then also I will tell you, even if a pathologist is very good, he might get confused whether this is a lymphoblast or a myeloblast. That is why two very important things for us are the special stains and the markers. What is a special stain which we use for a lymphoblast, students? The answer is pass. That is another separate question you have to remember. And what is the special stain which we use for myeloblast? I'm so sorry. What is the marker which you will use for lymphoblast? If it is BALL, it will positive for B lymphocyte markers like CD19, 20, 22, PAX5, etc. And if it is a TALL, it is positive for T cell markers like 1, 2, 3, 5, 7. Understood? Easy? Now let us move to myeloblast. That means if my patient has AML, the peripheral smear or the bone marrow aspirate is going to look like this, right? So how do you differentiate between a lymphoblast and a myeloblast? A myeloblast, students, has cells with moderate cytoplasm. In comparison to a lymphoblast, the cytoplasm is much more. The granules are present. Of course, all the cells of myeloid series have granules, right? Except for monocyte. So here granules are present. Smooth homogeneous chromatin. So in contrast to a lymphoblast, which has got very dark blue chromatin, here we have pinkish homogeneous chromatin and prominent nucleoli. So in this image, I'll tell you how to identify nucleoli. Can you people see these empty spaces, right? So these are basically the nucleoli. In the exam, if you are unable to identify whether this is a lymphoblast or a myeloblast, please do not take any stress, because even a good pathologist gets confused, right? What is important for you is the basics should be clear and the history of the patient should be clear. That will be enough to make a diagnosis and solve the question, right? What you should know is special stains. Sometimes in the MCQ exam, they will give you that the blasts are myeloperoxidase positive. You immediately think that these are myeloblasts, right? So special stain for myeloblasts are MPO, NSC, SBB, and the markers which are there are CD13, 33, 117 and myeloperoxidase. Easy, right? Next. So if I go in more detail, students, very important image which can be asked, students, is this, in which can you see a rod-like structure in the cytoplasm? This is actually a OR rod. So students, if I see a OR rod in a cytoplasm of a blast, we definitely think that this is a myeloblast. OR rods are never seen in a lymphoblast. So the answer is going to be, this is a myeloblast. That means my patient has got AML. And if there is a bunch of OR rods in the cytoplasm, here, can you see? So many OR rods are arranged in a crisscross pattern in the cytoplasm. That cell is called as a fagot cell. What is that cell called? It is called as a fagot cell. Fagot cell is basically a crisscross pattern of OR rods in the cytoplasm. Understood? A lot of questions are asked from this. Which type of AML shows maximum rods? Answer is AML M3. Which type will show a phagot cell? Of course, which has maximum rods will show phagot cell. That is AML M3. Right, so these are the common questions which are asked. Understood? Let's move to the next image, students. Peripheral smear of CLL. So now you all know that if I get a peripheral smear of ALL, I will get lymphoblast. If I get a peripheral smear of AML, I will see myeloblast. Now what if you get a peripheral smear of CLL or a question on CLL? What you will see? Now remember students, CLL is a lymphoproliferative disorder. So what is proliferating? The lymphoid cells, right? Usually the lymphoid cells are not immature. They are mature lymphocytes. So two very important things to remember for CLL are mature lymphocytes along with the presence of smudge cells, right? So in this image, can you people identify these cells? These are actually the mature lymphocytes. In addition, students, I see smudge cells or basket cells or parachute cells. So they all are seen in CLL. What are smudge cells? Why are they seen? Because the lymphoid cell in CLL has a very fragile cytoplasm. So when I make a peripheral smear, the cytoplasm gets smudged. That is why it is called as a smudge cell, right? This is also a B cell disorder, usually seen in elderly patient. Remember, the patient can present with lymphadenopathy or fatigue or pallor. In addition, in the history, please look out for autoimmune hemolytic anemia. That is another additional finding you might see, right? If I tell you the markers, they are usually CD5 positive and CD23 positive. This is also very important MCQ which you have to remember. Clear? CLL over? Now let me move to the next one, students, that is CML. Now you have chronic myeloid leukemia. Tell me, what is chronic myeloid leukemia? It is a myeloproliferative disorder. That means what is proliferating? Myeloid cells. Now this is a very unique type of CML and very commonly asked in MCQ exams these days. Why? Because all cells of myeloid maturation will be seen in the peripheral smear. So my peripheral smear will start looking like a bone marrow because I will see mature precursors of WBCs like promyelocyte, metamyelocyte, band forms, neutrophils, along with a very important thing, students, that is basophilia. So in the MCQ exam, if they tell you that the patient has basophilia, think in terms of this thing, CML or any myeloproliferative disorder, right? So peripheral smear starts looking like a bone marrow. All stages of myeloid maturation are seen along with basophilia. Can you see? The TLC is very high with so many cells, promyelocyte, myelocyte, metamyelocyte, etc. What are the other clues in the history which might be given for a case of CML in the exam? Chronic leukemia, so usually old age. Massive splenomegaly can be another thing. What is the translocation which you see commonly? That is another MCQ which can be asked in FMGE. It is T9 is to 22. That is the most common translocation which we see in CML. T9 is to 22, which leads to constitutive activation of tyrosine kinase, right? And because that is why students, we use imatinib mesylate or Gleevec for the treatment, because that is a tyrosine kinase inhibitor. Got my point? And this is how the peripheral smear is going to look like. What is the best investigation which you will do? I will do a FISH test, fluorescent in situ hybridization, to look for T9 is to 22. Another important thing is we do a score, students, that is called as the NAP score, neutrophil alkaline phosphatase score. That score is decreased in patient of CML. Very important question, another which you can remember. Clear? Let's move to the table which I have created for all of you students so that you do not get confused in a question of leukemia. ALL, children, CLL 70 years, CML middle age to elderly, AML also middle age to elderly, any age, right? Clinically, ALL might show CNS, testis, lymph node involvement, can have pallor, fatigue, hepatosplenomegaly. AML, very characteristic two things which you have to look in the history, students, is gum bleeding or gum swelling or hypertrophy. One very important thing. Another is chloroma. What is chloroma? Soft tissue involvement. If AML involves the soft tissue, usually it is in the periorbital location, it is called as a chloroma, right? CLL, I've told you lymphadenopathy, and CML look for massive splenomegaly. The most important point which will be clue is the peripheral smear, ALL more than 20% lymphoblast, AML more than 20% myeloblast, CLL I told you lymphocytes mature along with smudge cells, and CML all cells of myeloid maturation along with basophilia. Stains I have already told you for lymphocytes, lymphoblasts and myeloblasts. Markers I have already discussed. Cytogenetically, AML, the most common translocations are these. CML T9 is to 22, and for CLL, it can be del 13Q or 17P. Very important table. So now you know the kinds of lymphomas which can be asked. You know how to identify the various types of leukemias. Let me tell you some additional things, students. One, myelofibrosis might not be asked in FMGE exam, but it is important for INI-CET or NEET exam, students. When you do a bone marrow aspirate, all of you know, we get a dry tap. But when we do a bone marrow biopsy, we see black colored fibers on the reticulin stain, which is a silver stain. Any silver stain always produces a black color. In this image, can you see these black colored fibers? These are basically fibers in the bone marrow. The aspirate is a dry tap. Understood? Also in the history, there is a patient with massive splenomegaly. Correct? Next, students, let's move to the next image. Okay, very important topic, students, multiple myeloma. So you should know how to identify a plasma cell. Yeah, you should know how to identify a plasma cell. So in this image, students, can you people appreciate these cells? It is an oval shaped cell. Everybody can see. It has an eccentric nuclei. It looks as if nucleus will move out of the cytoplasm, right? So eccentric nucleus, and it has a cartwheel or clock face chromatin. Can you people see? This looks like a cartwheel or clock face. Very important point which I use for diagnosing that this is a plasma cell is a perinuclear halo. Can you all appreciate that there is an empty space around the nucleus? This is called as a perinuclear halo or a perinuclear HOF. This is seen in a plasma cell. This is how you will identify a plasma cell in a patient of multiple myeloma, right? Now, whenever we have a case of multiple myeloma, you can be given a lot of things in the history that the patient might be having Bence-Jones proteinuria, might be having bone pains or pathological fractures and all, right? Bone marrow aspirate shows a very characteristic cell, and the image was asked in FMGE exam 2 years back, students. This is the image. This is called as a MOT or a modular cell because of the a high amount of abnormal immunoglobulins, right? In the cytoplasm, can you see these grape-like clusters? And that is why these grape-like clusters are called as a MOT cell or a modular cell. This is seen in multiple myeloma, correct? Next, students, in multiple myeloma, you will see two types of body also. One is called as a Russell body. What is a Russell body, students? It is an intracytoplasmic inclusion. Can you see here in the cytoplasm, some inclusions are seen? These droplets are seen. So these inclusions are basically called as the Russell bodies. And whereas if these inclusions are present in the nucleus, these are called as the Dutcher bodies, right? Can you see inclusions in the nucleus? They are called as the Dutcher bodies. So on bone marrow aspirate, three important things in multiple myeloma. One is a MOT cell or a modular cell, that is a grape-like cluster in the cytoplasm. Intracytoplasmic inclusion called as a Russell body, and an intranuclear inclusion called as the Dutcher body, right? And lastly, students, if sometimes this image can also be given in multiple myeloma, the X-ray of the skull, which shows lytic or punched out defects. So when they give lytic or punched out defects in the skull or the bones, you have to think about 1DD also, that is multiple myeloma, right? With the students, I have finished off the important disorders of WBCs in this video. I hope you like this video because this is a very, very helpful video for all MCQ exams, especially for FMGE, right? Thank you so much, everyone, and all the best. Happy studying.